close to 2 o'clock. Welcome to everybody this afternoon to the Health and Wellbeing Board, the 13th of December 2023. We have another hybrid meeting today, which means that we'll be sort of working to two masters, so to speak. The first hour or so will be spent here. So between 2 and 2:45 we'll deal with the matters that are on the agenda. At 2:45 we will decamp to the assembly rooms where tea and coffee will be served, and that will be followed with a workshop, dynamic workshop on health and wellbeing boards. How did we get here? Where are we going? Not just today, Jonathan, just esoterically speaking now. And where are we going to fit into the new world of ICSs and that type of thing? So it'll be creative and no doubt very, very interesting. So I'm going to start off simply with the minutes of the last meeting. You may remember that it was a two-focused meeting. The director gave a talk on severe multiple disadvantaged people, and we followed that up with something to do with making a smoke-free Nottinghamshire. The minutes are for noting only rather than comment on, and I'm going to go through them page by page. Page 1, page 2, page 3, and page 4. All those in favour? Seconded? Yeah. Can we make a note of that? Fantastic. Apologies. Have we got any apologies today?
Thank you. So far today we've had apologies from Councillor Tidewell from Boxstow, being substituted by Councillor Falvey, and an apology from Councillor Crosby. We have Dr Elson substituting for Dave Briggs today. We've also had apologies from Stephen Short, and Victoria McGregor-Riley and Oliver Newbold.
And the most dedicated people, like the ICB, not only sent to Devon. I think that's dedication beyond imagination. The partnership working, yes indeed.
I wonder if we could just also minute Melanie Williams' late apology. She's having to cover for a number of sicknesses in her senior team that have arisen today.
Fantastic. Can I ask if there's any declarations of interests by members or officers, pecuniary or non-pecuniary, to declare now, or if you remember during any item that we're discussing, feel free to put your hand up and inform us at that point in time. Nothing noted. And we're going to move on now. We've got items 4, 5, 6 and 7, water fluoridation, the Better Care Fund, the Chair's report and the work programme to get through. And we're going to start off with item 4, water fluoridation in Nottinghamshire. And water fluoridation is one of those things that you'll be aware of that we've been talking about for quite a long period of time. And we're going to introduce this update around where we've got to with regards to the campaign to fluoridate the water of Nottinghamshire. You may remember some time ago in July I brought a motion before full council declaring that the 30+% of kids with severe dental decay represented a burden of disease on the population of Nottinghamshire. You may remember I pointed out that 30% of Nottinghamshire was already fluoridated, meaning that this was an actual health inequality and no less than an inequity, because we've actually chosen to fluoridate 30% of the population of Nottingham and leave the other 70% unfluoridated. And not only that, but it was preventable. So based on the fact that it's preventable, based on the fact that it's health inequality, based on the fact that it's a burden of disease, we were nothing less than started that intervention to bring about fluoridation in Nottinghamshire for the first time since 1970, some 50 odd years. And with that as the background, I'm going to pass over to the Deputy Director of Public Health, Vivian Robbins, to tell us where we are.
Thank you, Councillor Duddy. So thank you, everyone today. So yes, for those of you that don't know me, I'm Vivian Robbins. I'm Deputy Director of Public Health, and what we're here to do today is inform members of where we are in terms of water fluoridation in Nottinghamshire as we stand, to seek your comment on the work programme to hopefully help support our advocation for our ambition to expedite our ambition to have water fluoridation for all of our residents in Nottinghamshire, not just the 30% that Councillor Duddy is talking about there. So can you just go on to the next slide, Lizzie, please? So thank you. So water fluoridation is a safe and effective population intervention which with really strong evidence base that shows it reduces the scale and likelihood of tooth decay, because we know that oral health has a significant impact on our overall health and well-being and has a range of impacts in terms of children's hospitalisation is one of our key areas to consider as well. So in terms of what water fluoridation does, water fluoridation is fluoride is a mineral that is naturally occurring in many water supplies, and what the intervention water fluoridation does is to tweak the level of fluoride in that water supply to create that optimum level for the best oral health outcomes. And we know that that level is 1 part per million, and there are areas across the UK and across the world where we have that naturally occurring. So it is about trying to mimic a naturally occurring benefit and reduce that health inequity that Councillor Duddy has talked about. About 10% of the England population already has water fluoridation, whether that's artificially or naturally, and as I say, about 30% in Nottinghamshire already do, and that's predominantly in Ashfield, Mansfield, and Bassetlaw, and a very small area in Newark and Sherwood. So in terms of the benefits, in terms of where we are now, we know that although our rates of oral health in our under fives are similar to the England average, we still have about a fifth of our under fives that experience tooth decay. We also know that we've seen the benefits of water fluoridation. So if we compare an area like Newark and Sherwood, which is predominantly non-fluoridated, we know that our rates of tooth decay in under fives are looking at the sort of 23-ish%. If you compare those with areas of Mansfield and Ashfield, where we would expect to have poor oral health, because we know that poor oral health outcomes are linked to deprivation, we're actually seeing that there's a significantly lower level of tooth decay at around that 16-17%. If we compare that with areas that are similar to those, so if we compare Mansfield to its neighbour, which is an area that has similar demographics to Mansfield, we know that the level of oral decay in their under fives is 32%. So we are seeing that water fluoridation, as well as a number of interventions that we do in Nottinghamshire to improve our oral health, are having benefits, and that's what we want to do for all of our residents. Next one, please. So in terms of what we've looked at now is we've done some modelling around and looked at the evidence base in terms of what the impact would be is it if we could expand fluoridating all of our water supply and not just for that 30% of our population. And this slide summarises some of those key benefits. So we know there's 35% reduction in delayed missing and failed teeth in under fives. We know that there's potentially 15% less children that would have no decay. We know that we can reduce hospital admissions for teeth extraction by about 30%, and that's looking at actual numbers. We're looking at about 115 fewer extractions per year, and we know that for our under 10s, actually going in and having their teeth extracted is one of the key reasons why they would be admitted to hospital. So it's a really important area to consider there. And although the benefits for water fluoridation are particularly apparent for our under fives, because we know it does our teeth developing, and also our most deprived areas, there are also benefits for our adult population, and you can see some of the figures around that. But what I would like to highlight is that in terms of there are a range of things we can do to improve our oral health for our residents of Nottinghamshire, but water fluoridation has an extremely strong evidence base and has an extremely good return on investment. So we know that after 10 years, for every pound that we spend, just under £21 would be returned in terms of investment. In terms of where we're at and the time scale, so there's sort of two phases to this area of work. Phase one is gain support of partners, which is one of the key things that we're keen to do today. And we're already on a really strong journey across Nottingham and with Nottinghamshire City as well. So we're at a really important moment where we can work collectively to come together and draft a letter to the Secretary of State for Health, who now has the legal responsibility for varying, expanding and changing water fluoridation across Nottinghamshire. So we're building on the motion that has been passed in July from Councillor Doddy's leadership and really thinking around how we're gaining that support locally to get that letter sent to the Secretary of State and ensuring that we've got the strong evidence base around that and the support from a range of partners. And we can give you some more information on that if people would like to see that. Our aim is to get a letter to the Secretary of State for Health and Social Care by early January, and then we will wait and see what their response will be, because then we move into phase two. So although we don't have legal responsibility for water fluoridation now, we can write to the Secretary of State to really show our case around why we think here in Nottinghamshire we should be prioritised to expedite that real ambition to expand our fluoridation scheme. Phase two is more in the hands of the Secretary of State for Health and Social Care, and that involves a range of feasibility studies. So can this actually happen in terms of working with the water companies? There'd be a significant public consultation, so we need to make sure that our residents are informed to make the right decision for themselves, and then it comes on to the decision from the Secretary of State to proceed or not. If that decision is made, then there's quite a significant amount of building infrastructure, and it's quite a specialist structure that we need to consider. So we do need to be aware that this will be a journey. This is not something that we're going to see overnight, and it could be 3 to 10 years to be successful. Next slide, please. So just in terms of next steps and recommendations, so we've talked about where we'll be at with many of these steps. We would absolutely make sure that the Health and Wellbeing Board is informed of our outcomes, because we will be really keen to work with partners to really build that social momentum and that engagement with our population, because it will be coming down to more local conversations around what does this mean for our local people if we are hopefully in the position where the Secretary of State is looking and prioritising Nottinghamshire for us. So what we're asking for the board to do is comment on and support the work programme to champion better oral health outcomes for our children, but also for our wider population, and really support us in that advocating for that expansion of water fluoridation in Nottinghamshire.
Thank you very much, Viv. It's a unique time. People say to me, why did you take an interest in fluoridation when nobody had done it for 50 years? And it was largely due to the Health and Social Care Act 2022, the same one that created the integrated care services that we're all part of. But as Vivian rightly said, for the first time took the responsibility for water fluoridation from local authorities and put it in the hands of one single individual, the then Secretary of State for Health, Stephen Barclay, and of course he's been changed now to Victoria Atkins, etc. So we had previously spoken to the Secretary of State for Health and said to him that we were providing this letter and bringing it down to him. So we're going to try and arrange to bring it down to Victoria. But it was a unique opportunity that actually, prior to that, nobody over 50 years could agree. Lots of places had tried. I think the most recent one that had failed was down in Portsmouth, where they couldn't get people to politically agree on a locality basis because the water companies didn't show political boundaries. The fluoridation wasn't over political boundaries. And therefore this took local politics out of it and put it in the hands of the national politics and one single individual. So that made it particularly attractive to reignite the idea of doing it for the first time in 50 years. And it has to be said, Vivian, whenever we've gone round and talked about this to the variety of people we've talked to, the appetite and the enthusiasm for delivering this is extraordinary. We were talking to 7 other ICSs a month or so ago about this, and every single one of them wanted to follow and know how we got to the position we're in and how they could actually follow suit, as well as obviously this being recommended by the World Health Organization, the British Dental Association, etc. It sort of beggars belief how we've got here 50 years later and we haven't actually done it. I think COVID threw it into a clear perspective with the deterioration in dental health and the inability for kids to actually access mental health afterwards. So that's how we got here, and it's been a fantastic team effort with huge amounts of input from a variety of sources. So I'm going to open it up to questions now. If anybody's got any questions around fluoridation of the water supply of the 70% of Nottingham unfluoridated, and I'm going over to you, Councillor.
Yeah, sorry for being late. I got delayed by the traffic on Understood Street because of the incident this morning. I just wanted to make a quick point, really. So, whilst I think prevention is better than cure, there's a lot of mention of oral health in the report, but nothing to mention about the lack of dentistry for children or families who, I mean, it can only be described as a bit of a dental desert in Nottinghamshire at the moment in terms of trying to access a dentist. So, whilst prevention is better than cure, I think it's fundamental to the human rights of children to be able to access a dentist, particularly when they're going through the different stages from baby teeth to more adult teeth. So I think actually in terms of hospitalisations, quite a lot of families are actually going to hospital because they can't access a dentist. And I think we need to know in terms of, or what I'd like to know in terms of the question is what are we doing actually to try and resolve that issue through the ICB and all the other public health measures. Thank you.
Yes, it's always the question that comes up at the same time. You know, if we haven't got the dentists, how are people going to achieve that? And again, as I said, COVID threw it into a particular light in that it was one of the few post-COVID areas that recovery did not happen at the speed of other areas in terms of children returning to see dentists, etc. Interestingly, we are uniquely positioned in that this year the commissioning of dental services for Nottinghamshire fell under the responsibility of the Integrated Care Board. So it was a year after other responsibilities, but for the first time the funding and the responsibility for the commissioning of the services for dentistry is now within the control of the ICB. So we're in unique waters in that respect. I'm going to throw that open to anybody. John, Dave, go ahead, Dave.
Well, my comment was going to be to in the first instance to thank you, Councillor, for your support for what is an essential preventative measure, which is absolutely what we need to focus on today. And it was just to add a brief comment to that before inviting through the chair Dave to comment from an ICB perspective, and that is whether the United Kingdom and Nottinghamshire has all of the dentists that they need or only some of them. Fluoridation is what we need to exercise ourselves about and get in place as soon as we can. So we absolutely need to remain focused on that. For as long as we're in a situation where we don't have as many dental services as we might like, an intervention like fluoridation will actually reduce some of the demand and need for some of what those dentists were otherwise were having to provide. So both now in the situation we're in now and in the future, fluoridation is absolutely the right thing for Nottinghamshire. But through the chair, may I ask Dave to?
Absolutely.
So the dentistry is a very important service, and dentistry and poor dentition is linked to poor outcomes for other health measures other than just the dentist, other than just your teeth. So it's got significant alignment to heart disease, stroke, and other conditions due to the inflammatory nature of oral health. The responsibilities for commissioning dental services passed to the ICBs relatively recently, and we're currently looking at the number of projects that were initiated at a regional level to improve the number of people who are undertaking NHS dentistry in Nottinghamshire and the wider region, but also how we may keep those people when they are here. And there's a number of initiatives around looking at the skill mix and the input from other oral health professions as well as dentists to meet that workload, looking at how we might get some of those dentists in the right part of the city and the county because they're not always located in the best place, and also looking at how we can increase the workforce and looking at things like international recruitment. So it's certainly a challenge. We start from a very low place nationally in terms of the attractiveness of NHS dentistry to our dentists we are training, and we also start in a difficult place not having a dental school in the East Midlands, so we have to net import all our dentists who don't have any undergraduate training experience in East Midlands, which means it's a challenge to start with. The ICBs across the East Midlands have come together on this agenda and looking at how we can promote the East Midlands as a place to come to do your final part of training in your after you've qualified to the East Midlands to increase the flow through, and reviewing the projects that were done at a regional level in terms of the effectiveness, both in terms of cost but also outcome for our people. I know the HOSC Health Scrutiny Committee are keen to look at our work on this. I'm not sure if we've got a date in the diary, but I'm sure one's coming if it isn't in already, and it'd be useful to bring the output of that here so you can see what's happening with NHS dentistry. But we do recognise it's a significant and ongoing challenge, and probably one of, along with community pharmacy, probably two of the most challenged community services that we have currently on our patch.
Vivian, did you want to say something?
Yeah, thank you, Joe. So it was just adding on to Dave's comments there around the Health Scrutiny Committee. So there has been a report already taken to the Health Scrutiny Committee. I think it was sort of summertime, and I'm pretty sure it's on the agenda for early 24. It might even be the January meeting. So there'll be much more detailed response coming out then.
Thank you. And obviously fluoridation and our route to fluoridation doesn't negate the significant work done by the council in its interventions through schemes such as brushing buddies, going into schools, providing toothpaste, providing free toothbrushes, education to children and their parents, etc. That is ongoing, and dental care through fluoridated toothpaste, etc., still has a role to play, but it's only active while the toothpaste and the fluoride is in your mouth, whereas if you're taking it through water, it passes through your systemic system and into your saliva to work on the cariogenic bacteria that are in your mouth, breaking down your teeth, and that's the difference in the success rate. Councillor Place.
Thanks. It's actually Councillor Gowland, so I've swapped permanently actually, but anyway, it doesn't matter. Yes, this is obviously a really good idea, and I'm very grateful for you to bringing it forward for the people of Nottinghamshire. I was going to raise the issue of access to dentistry, which has obviously been discussed quite a lot. I wonder, will the data going to Health Scrutiny Committee include the location of dentistry now across the county, so we can understand where the hotspots are, so to speak? Just picking up on some of the things that were said before, if there's no dental school in Nottingham, is it possible for this committee organisation, the ICB, to talk to universities, because obviously we have large medical schools? I appreciate it's not a quick fix. Coming to the fluorination again, I absolutely support this. I want to make it completely clear, I completely support this. However, we know there will be some people who are concerned, and we have had a conversation about this, but I think it's really important to be upfront and ahead of that game in explaining to people, and explaining particularly the data, which has been so compelling, how we're going to how this is positive, the problems of not doing it, the long-term problems of not doing it, and what the risks aren't in terms of this, because I think there will be a level of pushback against this at some point, unfortunately.
Yes, thank you very much, Councillor Gowland. Indeed, yes, we have been contacted by people who are not very keen on fluoridation, to put it mildly, and we have a research crew, I think, based up at Kingsmill or somewhere like that, who constantly daily look for articles around fluoridation, look for any adverse paperwork around fluoridation, and are continuously keeping us up to date on any changes around fluoridation locally, nationally and internationally, etc. So all of the side effects, all of the potential challenges around dental fluorosis and other things have been exceptionally well researched. We have addressed them in a number of different papers, etc., and are completely at a position that we can explain to anybody any of those particular questions. Dave?
Yes, I think you mentioned, didn't you, that you wanted to look at is the supply where the need is and where the demand is. I think, yeah, that will form part of the discussion with the HOSC in January. I think just to recognise we're on a journey here, we're starting from a very challenging position. So the position in terms of demand is outstripping supply really quite substantially nationally as well as within Nottingham. So it will be quite a journey to get the level of access that we'd like to see.
Thank you, Dr. Briggs. I've got Councillor Tom Smith.
Thank you, Chair. Just 2 points I want to raise. The first one, I'm clearly very on board with this, obviously. But the first one, I perhaps naively hadn't realised it could be an up to 10 years process. I appreciate there's various aspects that are, once we pass it on to the Secretary of State, it's kind of out of our control to some extent. But at what point do we think we'll be able to narrow that 10 years down? Was my first point. And my second point was it's just been made by Councillor Gowland, actually. It's just to kind of reaffirm this sort of thing will excite those who are conspiratorially minded. So I'm very glad to hear that we're on it and we've clocked that.
Vivian Robbins.
Thank you for your questions, Councillor. So I think in terms of the timescales, we don't have as much control over the timescales now because obviously that has moved to the Secretary of State in terms of they will have a defined budget in terms of how much they have to invest in fluoridation, and they will also be thinking around where they're going to prioritise that in terms of level of need. We know that there's a lot of work going on in the North East at the moment, and there will be a lot of learning for that in terms of the process since it's moved to the Secretary of State for Health and Social Care, but also understanding what lessons we can learn in terms of where there is that feedback from the population in terms of what they are feeling a little bit unsure about, so that we can learn from that. In terms of what we can do in Nottinghamshire to try and reduce that timescale and that process, there's something for us around how we can come together collectively around getting Nottinghamshire with the support of Nottingham City and RICS, and potentially looking at our broader partners around how we make the Secretary of State prioritise Nottinghamshire so that we're at the top of the list. Because there will be a defined pot in terms of money for looking at feasibility studies, there will be a defined amount of resource for looking at public consultation, and there is very specialist support in terms of that infrastructure. So I suppose for me there's something around how can you guys help us in terms of, one, making sure that our population are really aware of the benefits of fluoridation, but also how can we support you in terms of where you are getting questions which are legitimate questions, that we can support you to be able to confidently respond to those, and we will be absolutely working with you to be able to do that. But there is something also about how we keep Nottinghamshire high on the agenda, and I think a lot of the work we've done so far locally is around building that momentum across the ICS, including our health colleagues who have been very supportive, and anything that we can do to maintain that, I think, will be the things that will make the difference. And then we will have to just work with the Secretary of State as much as we can, hopefully, once we do get into that phase 2.
And in addition, Councillor Smith, although the Secretary of State for Health has assumed full responsibility for that, and the initial cost is thought to lie with the Secretary of State, it allows for provision of the Secretary of State to ask other partners to contribute in a varied way, be that the water company, be that the county council, be that other partners. So who knows what role that may play in the future. Any other questions on water fluoridation before we sit back and wait for the next 10 years? No? And then I move the recommendation to comment and support the work programme to champion better oral health outcomes for children and young people and advocate the expansion of water fluoridation in Nottinghamshire. Can I have a seconder for that? All those in favour? Thank you. So we're going to move on now to item 5 on the agenda. Item 5 on the agenda is the Better Care Fund. The Better Care Fund in previous years has never really ignited the imagination, but now, due to our review, due to the increased Better Care Fund, due to the £100+ million fund and the opportunities to actually do some bespoke spending in place-based partnerships, etc., it has become increasingly interesting to people. It's our responsibility statutorily as the Health and Wellbeing Board to sign off the Better Care Fund on a quarterly basis. And I'm now going to pass over for that report to be spoken on by Naomi Robinson. Can you hear us, Naomi?
I can. Thank you, Councillor D. And firstly, just apologies I couldn't attend in person today. That would have been the preference, I know, so apologies for that. So as you introduced, this is the Q2 Better Care Fund performance report. We were required to submit this to NHS England on the 31st of October 2023, so it's coming to board today for ratification and information, so you understand what we've reported on. Just to note that reporting quarterly on the Better Care Fund was stood down during COVID, so this is the first national reporting template we've had to complete, and this quarter's template focused on the metric performance and an update to system demand and capacity planning around intermediate care, so services preventing admission and supporting discharge from hospital. It didn't include financial updates this quarter. So just a quick reminder of the metrics. So we're measured for the Better Care Fund on avoidable admissions. So those are conditions that are considered to be avoidable if there's proactive care. So it's your long-term conditions, COPD, diabetic management, that if with that right kind of proactive care, you can avoid admission. So we've given you a little flavour in the report alongside these metrics of services that we've got in place through the BCF that support each one to be delivered. So for avoidable admissions, we've just referenced here our urgent community response service. So that's a 2-hour response to people who are at acute risk of admission. The service takes urgent referrals from health and social care professionals, provides a same-day response within 2 hours if required to avoid unnecessary either admitted to hospital or home care admission. So it will respond to either need, and it will put in place a short-term care provision that could include practical things like urgent equipment need, reduce of things like future risk of falls, etc. So that's the avoidable admissions metric. We've got a new metric this year that was introduced through BCF around falls. So that's measuring particularly hospital admissions due to falls in people over 65. we've referenced here some work that's happening with our primary care networks and GP practices around a slightly more upstream frailty work around identifying and case finding people at risk of frailty, and make sure we've got up-to-date scores around the severity of their frailty, and then putting in place targeted support for those people that are at increased risk. So there's a little flavour there in the paper around how those primary care network efforts are going. That's quite a new metric for us. So for the first quarter, it's been measured. And then discharge to usual place of residence. So this is measuring the system effort to get people back home out of hospital, supported at home, not needing expedited care or growing care in kind of residential needs. And we've referenced here the performance around our multiple disciplinary teams, so our transfer of care effort. So through the BCF, we fund various roles and coordinating roles around what we call transfer of care hubs. So those take those dynamic support teams to identify people who've been discharged, make sure they're on the right pathway. So can they go home with a package of care? How quickly can that package of care be put in? Are there additional needs around that in terms of housing or practical equipment elements? And the monitoring of their support once they've been discharged, and then residential admissions. So we're also measured on the number of people who are entering into long-term care, and we've referenced here that the additional capacity and focus on home care, so supporting people at home, is how we're as a system reducing the number of people who are needing that long-term care and support. And then reablement. So this metric looks at people who have been cared for at home, discharged to home with a package of care, and that they're still at home 91 days after. So it's trying to sense check it. Are we discharging the right people with a package of care at home, and is it being effective? So for all of those metrics that I've just talked about, we are on track to meet the targets that we set ourselves locally, with the exception of residential admissions, where we are slightly off target. So we wanted our average number of monthly residential admissions to be 82 per month, and we're slightly above that at 91. So we are, like I said earlier, expecting that our efforts around improved home care and availability of capacity to support people at home will see that reduce. And I think looking at data, colleagues have said that is reducing, although not yet below the target level. And then I'll just quickly reference that we had to update our capacity and demand modelling for intermediate care, and that we've got just some key points in the paper there around capacity for pathway 1 has been increased. We've put things in place like 10% increase for seasonal winter pressures, and that we are looking, we had to report to the national team that in terms of surge or unexpected demand, that we've got our urgent community response team in the community, but also our transfer of care hub that will manage any kind of change in demand if it happens and there's unexpected demand on the hospitals. I won't go through. So there is another section there that talks just highlights again to the board, because I think this increasing kind of involvement in understanding what the services behind the BCF are. So we've just referenced there at point 9 that was a recent carer strategy launch event on the 16th of November. So of course our carer support services are all through the BCF. We fund them as BCF services, and we've got again the PCM pilots around frailty. And we're looking at our transfer of care hubs and making sure that they are optimally set up, against each acute hospital flow. And then I will just finish on the output of the local BCF review. So we had the workshop that you referenced earlier, Councillor Doddy, and then as an output of that, we are looking with colleagues are looking together around. There was a lot of discussion there around prevention, frailty. Can we get better at integrating services around there? So we're looking at establishing a deep dive into the Commission services around that area, and whether there's room to deliver better outcomes, reduce duplication. We've probably through the review identified there may be some duplication or some work we can do to get services to work better together. So around the prevention, so the services that are there to support people before they need formal packages of care, we're just looking at doing more of a deep dive commissioning review. So the recommendation is to ratify the Quarter to return to NHS England.
Yes, thanks, Naomi. Clearly, keeping people safe in their own homes is one of the key factors in reducing the demand on the acute services over the winter. Have we seen much more technology-enhanced care creeping in order to keep people safe in their own homes?
So actually, sorry, I don't want you to come back.
No problem. Dr. Bartolomeusz.
So I think Dave and Jenny might come on to that one, but very quickly before I add on to that, I think in terms of the sort of projects which you said, so we, again, locally as a system, we've probably led on this, which we started with Call for Care in mid-North, and then those teams were responsive to calls, and that's what helped build on the urgent care responsive. For example, the PCN pilots, proactive care, one around the Asheville North PCN with the proactive care around respiratory reviews. We are seeing significant outputs in terms of keeping patients at home, having this care plans in place. So I think this has made a big change in terms of trying to get those frontline services, get those interventions in place well before winter, where particularly for respiratory illnesses, keeping patients at home and the care plans. And this also actually, during COVID, it was one of those areas where we as a system were quite proactive in supporting our vulnerable population in the community care homes. In terms of digitally enabled care, would it be Dave or Janine taking the answer? Janine, thank you.
Thank you, Chair. In terms of digitally enabled virtual care, we are increasing our number of virtual beds across the county by both beds where people can be discharged earlier from hospital and be supported by the healthcare teams by using digitally enabled monitors at homes where we can take their readings at home in their own space, and then the healthcare team can virtually review those and continue to monitor them at home for a period so they don't have to stay in hospital as long. We also are increasing our number of beds where citizens can avoid going into hospital at all, so that they can be monitored virtually at home by use of digital technology. Again, feeds back into the healthcare teams, and that helps to avoid them being admitted at all. So they may just need that increased care for a short period of time and can go back to being under their GP care. So all of those beds and that supportive technology is increasing as we speak.
Thank you, Dr. Elson. Dr. Briggs.
Thanks, Naomi, for the update. I mean, this is one of the core partnerships, isn't it, that we're working on about how we do this work. And the modelling that we've done jointly as an ICS shows that this particularly frail community in the county and in the city are slightly younger frail people. If we don't act jointly and effectively together, it's going to lead to a really challenging time for both our social care sector and our health sector. So I think I really look forward to working with them and encouraging everyone to be involved in that workshop about how we can work together on these services to be more effective. I think it's fair to say some of the work we've done today is pretty impressive, actually. So the joint work we've done on a number of these is I think up there among some of the best in the country. However, we still need to do a lot more and go a lot faster if we're going to have the sort of health and social care system that we'd want for our families and for ourselves. Hopefully in the distant future, but we are feeling at the moment maybe sooner than I anticipated.
Thank you, Dr. Briggs. Councillor Wheeler.
Yeah, thank you, Chairman. Thanks for the report. So my big bit I want to concentrate on is the disabled facilities grant. So in Rushcliffe, we received the lowest share of the pie, so to speak, but we are having massive pressures put on us in terms of the amount of work that needs to be done on homes. And last year alone, we had to fund a significant amount of money from our own capital reserves towards it from the district, and quite frankly, we can't do that going forward. It's not sustainable with the finances we have, and same with other councils. So what I ask is that as a board, we can review how that funding is allocated and what we can do going forwards, because I'm aware that some councils have money that they are rolling over because, obviously got the funding and don't have the demand. But in Rushcliffe, we've got the oldest population in Nottinghamshire. It's going upwards, as it is everywhere. But we'll get a lot more referrals come back. Obviously, people need adaptation to their house. And what I don't want is to have to keep extending waiting lists that should be done when there might be money in the system that we can allocate. But also fundamentally, and I know I raised this at a couple of workshops ago, but look at the system we have now, because it's not tenable that every district council is doing their own thing in terms of handyman services and back house stuff. There must be a better way we can work together to put more money into the system that we can put into the home. So I just ask that we can look at going forwards, because there's definitely some improvements I think we can all do to make sure we get some more money into the areas that need it most. Thank you.
Thank you, Councillor Wheeler. We did get your query, and we have passed it on to the powers that be to find the solution to your question. I'm going to say, Lizzie, who did we pass the question on to? Richard Cameron. So it's in process at the moment, and we'll carry on looking into that. And as you rightly say, money spent keeping people in their own home is the only way that we can be successful, because we haven't got enough hospital beds, and we're never going to be able to put everybody through hospital care and residential care and respite care and nursing care. So we shall get back to you with that. Thank you, Councillor Wheeler. So I'm going to I've got 3 people here, then I'm going to go to the recommendation that we ratify the Better Care Fund Q2. The first one is Helen Smith.
Thanks, Chair. It was just really to note the really clear description of the processes and the services, but I think the focus on the personalisation, how the services work with people to ensure they're kept independent in their home, is really important as well. So there's no reference to the sort of personalised care approach from NHS perspective, or the strengths-based approach from adult social care. And I think as long as we can maintain that emphasis of how these things are delivering on that agenda, I think that would be really helpful. Rather than just the numbers, it's the how and the satisfaction of people.
Have you got that, Naomi? Yep, thank you. Councillor Flavey.
Councillor Falvey, but I'll forgive you for that one. Good to see prevention being top of the agenda. Prevention is great, but let's hope we get more than 1% of the total budget going that way. I just worry your figures look good this time round, but we've got a recruitment freeze until April. I wonder what impact that might have on achieving figures next time round.
Over to you, Naomi.
I'm just wondering if that query is more relevant for adult social care. Was it a recruitment? Mention a recruitment freeze.
But my understanding is it's across the board in the ICS, ICB.
Dr. Briggs.
So the ICB, the health aspect of the health and social care system has grown substantially over what we agreed and planned for over the last year, and we're currently working together on what it would look like for that rate of growth to diminish or to reverse. There's no current freeze on recruitment anywhere. In the ICB as an organisation, which is relatively small, we're having a prioritisation process where we look at vacancies on an individual basis about are they essential to deliver core services and statutory services, are they essential to deliver our efficiencies, improvements and effectiveness agenda, or is it possible that they could wait until the new financial year before those posts are arrived? There are separate and different processes in each of the NSH organisations, each of which is a significant quality and equality impact assessment to see if there is anything happening. on the services that are due to deliver, but there's no vacancy freeze in any organisation at this point in time in Nottinghamshire.
Thank you, Dr. Briggs. Councillor Gowland.
Hi, sorry, I've got a number of points. I'll try and be quick. So the first is coming back to Councillor Wheeler's point. The first part of this document says the Better Care Fund is formed by pooling contributions from these different grants. So I just quite like to understand that, because I'm also from Rushcliffe Borough Council, and I understood that the Disabled Facilities Grant was being managed locally. So is it part of it's being pooled? And more pertinently, I think, importantly, would it be possible to know what the delay in providing that grant is to residents, when they make an application, effectively what is the waiting list across the different authorities involved in the Better Care Fund in this region? The second question is, I think the digital beds are amazing, they're a game changer. I just wondered if those beds are counted as inpatient beds or outpatient beds from the point of view of this data. It says that in paragraph 6, monthly admissions is 10% higher than target. The number of people in residential care is beginning to reduce. There was some, I wasn't quite sure if I followed what Naomi was saying, because I think you were also saying they were over target, residential beds, residential care. I wonder if there's any idea of why monthly admissions are going up at the moment. Thank you.
Thank you, Councillor Gowland. Naomi, poor disability grant and its distribution, delays for applications for disability grant, rising numbers of people in residential care. Can you answer that as to your knowledge? Thank you.
Thank you. So the combination of fundings in the pool that are listed A, B, C, D in the paper, so those are all better. They're all Better Care Fund required spends, if you like. It's just that in our expenditure, the way that we receive it, it tells us you have an amount that has to be a minimum allocation for out of hospital community services. It tells us this is your allocation for disabled facilities grant. So that is set nationally, apportioned nationally, and then it's passed down to just district level. And then the social care funding improved IBCF. So that was a specific amount of money that came nationally to local authorities, but it had to come through the Better Care Fund, so we have to show it as part of our pool. And the same with the winter pressure grant funding. So kind of all those areas of spend nationally are kind of within the BCF. But that first one, minimum allocation, is our ICB commitment. We have to say we spend an amount of money on out of hospital care, and we have to show it as contributing to BCF. I think your second point around the disabled facilities grants around waiting times, I think that probably is tied up with a query that's with Bridget Cameron to respond to. So I won't comment on that, if that's okay. So I think that's tied up in any work that needs to be done around what we've just discussed around kind of joint benefit across the different district council working. So I think that's my understanding of the finance of it. It is one pool, but it's just we've listed them to give you a better understanding, I suppose, of some of the requirements around that spend. It's less, they're not they can't be separated, if you like, can't come out of the BCF, they have to be in the BCF. There are just different requirements around some of the spend. And I've forgotten one of those are the DFG points, I think. And the residential admissions. We weren't given any information around the raise. I don't know if local authority colleagues have a view, but yes, we.
Naomi, just going to bring in Dr. Briggs.
Yes, so the features in the Better Care Fund around rehabilitation and things to prevent admissions are not direct causes of residential cause, they're influencing factors. So if you get those right, you will influence a number of people who end up in long-term residential or nursing care. There are a number of controls outside those processes that will also increase your risk, and those processes are length of stay. So the current 21 length of stay in Nottinghamshire has been increasing. and that will undoubtedly have an impact on residential and nursing home placements due to the functional decline acquired in a prolonged hospital stay. So we've got a clear measure, which is what we absolutely have to, because the reason why we don't want people in residential care isn't about money, although money plays a part, is because your outcomes deteriorate and your independence and your quality of life worsens. So it's really, and I think we all know this instinctively, don't we, that actually it's a really good thing to do, because it means people are happily healthier and will essentially live longer lives with less physical disability. So the plan's the right plan, what we're looking at, and we've got ways of looking at it more effectively, but we have got some other factors that are less reliant on the BCF that could be pushing things the other way. So recognise the point, and we absolutely have to get back to that target because it's what we need to do for our communities. However, recognise that some of the things that we are working with the local authority on that don't appear in the Better Care Fund in terms of projects, but are contributing to that increased residential homestay.
Thank you, Dr. Briggs. I'm happy to get back to you, Councillor Gowland, on any answers that you need in addition to what you've heard outside the meeting, as indeed we will be following up with Councillor Wheeler's inquiry outside of the meeting. Thank you very much indeed, Naomi. I'm going to move to the recommendation that we ratify the Nottinghamshire Better Care Fund Q2 reporting template that was submitted to NHS England on the 31st of October 2023. Can I have a seconder for that? Second. All those in favour? Fantastic. Okay, thank you, Naomi. Right, we've got 2 minutes to 3. We should actually be having biscuits and coffee at this time. So I've got about 2 minutes to do the chair's report, and then we're going to go through to the assembly room. The chair's report is only going to mention 2 things, and one was that which was in the King's speech and the recommendation that we move to a smoke-free society, and smoking and smoke-free Nottinghamshire, i.e. a percentage of the population of Nottinghamshire of less than 5% smoking, would be the single biggest contributor to an improvement in public health and reduction in health inequalities that any of us could achieve in the whole of our lifetime. There's no doubt that smoking remains the biggest killer. There's no doubt that it's one of the top causes of life in ill health, be that through bronchitis or emphysema or lung cancer or circulatory problems or heart disease or stroke, etc. It is one of the single major contributors to why people spend years in ill health, not only how it shortens their lives. In terms of inequality, if you look at the people of Rushcliffe living 8 years longer than the people in Mansfield and Ashfield, a whole 50% of that is down to smoking. If we stopped smoking, we would have health inequalities in terms of life expectancy overnight, so to speak. 50%, it's that huge. And nobody would nowadays recommend that we promote, sell, or allow to be sold to the population a product that kills 50% of the people that use it. So the Prime Minister has proposed that from the 1st of January 2027 that we actually stop anybody who was born on the 1st of the 1st 2024 from actually buying cigarettes, and therefore people who are now 14 by the time they get to 18, with the limit rising by a year every year, will never legally be able to buy a cigarette. Now, this might not sound like something unique to you. You might have heard that it has been previously proposed in New Zealand. And New Zealand was going very, 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 very well until they had a change of government. And the change of government in New Zealand decided that rather than ban cigarettes, which they had done with an aggressive promotion, they thought that the £1 billion that cigarettes brought in tax could be better spent on the New Zealanders than that lost through improving health through stop smoking. So we will have challenges to it as we go down the line, but I'm just going to say At the last meeting, we were asked to do a response to the government's proposal, and I'm glad to say that we submitted our response to creating a smoke-free generation and tackling vaping problems in youngsters, and we accepted that we would do this because of the time constraints between the last meeting and this meeting, and we've done that and we have submitted that. I think we've just about run out of time, so I'm just going to say smoke-free Nottinghamshire. If we're thinking blue sky, Rushcliffe currently only has smoking of 4.9%, so it's already smoke-free. So parts of Nottinghamshire are already smoke-free. We just have to work on those parts of Nottingham which are not. I'm going to move on to the work programme. Lizzie, anything exciting in the work programme? You know that we've got severe multiple disadvantaged as a workshop fitted in February, following on from Director Gribbin's annual report.
Yes, absolutely, Councillor Jolly. So at the next meeting, we have the Chair's report. We've also got the JSNA chapter on suicide prevention and the integrated care strategy refresh, followed by a workshop on severe multiple disadvantage.
Fantastic. At 3 o'clock, 2 minutes ago, we're going to have an introduction to the Health and Wellbeing Board review. So I would welcome you all following us through to the assembly rooms, having a cup of coffee and a biscuit, and I think it's going to be a fascinating debate.